anatomy stuff dealing with the lungs and chest wall, and there is a portion of the chapter I am omitting from this class this semester, and I'll try to make sure I let you know some of the page numbers you can jot down. And I guess it's a decent amount of pages, just not 1 or 2 pages. So, this chapter opens with nervous control of the lung. There's the central nervous system, which consists of the brain and spinal cord. Again, we understand that there's going to be a signal coming from our brain telling our lungs when to breathe, or to breathe deeper, breathe shallower, etc. Now, there is what's known as the somatic nervous system. These are voluntary skeletal muscles. These are things under your voluntary control. You want to breathe faster? Breathe faster. You want to breathe slower? Breathe slower. You have that control. Now, there's also another system, the autonomic nervous system. We have involuntary, meaning I'm not in control of this, involuntary control of our smooth airway muscles. So, for example, right now, you and I can't consciously think and say, smooth airway muscles, dilate, or smooth airway muscles, constrict. We have no control of that. Our poor asthma patient who gets exposed to some allergen, because it's involuntary, their airway narrows and collapses. They can't consciously say, airway get bigger. That's not how it works. It's the autonomic nervous system, which some folks will reference autonomic meaning automatic. Okay, not under our control. We will get into, and I'll mention a couple other things here about nervous control of the lungs, but I'm going to save some of this discussion for a little bit later. There's a chapter on the brain and that activity, plus some of the things, and some of the things I will be omitting this chapter, we will touch on when we get to pharmacology, because medications can stimulate certain things and cause certain things to happen. All right, but let's talk about some of these nerves. So the phrenic nerve. Now these originate at our cervical nerves 3 through 5. So 3 through 5. And again, connect the phrenic nerve, there's 2 of them, right and left, down to our diaphragm. So the phrenic nerve connects, long story short, connects the brain to the diaphragm, the phrenic nerve. It can, unfortunately, be injured, whether it's a surgical injury, some sort of trauma, or even disease that can damage or impair the phrenic nerve. Now, if our phrenic nerve is damaged, how do you think the signal gets from our brain to our diaphragm to breathe? It doesn't. That's why I put here, it may paralyze the diaphragm. Now, thank goodness, I guess we have 2, because if one is not functioning, at least the other one could work and go to the diaphragm. I'll get to the diaphragm in just a second, but the diaphragm actually is 2 separate pieces, the right and the left. It's not one single continuous muscle. It is 2 separate ones. So if you think, okay, well, if there's damage to C3, C4, C5, could the patient not be able to breathe? And the answer is yes, they could not be able to breathe, but it is also possible that they could still support themselves by using what we call the intercostal muscles. Those are the muscles between the ribs. So those muscles would then be forced, because right now you're breathing all comfortable, you're not using your intercostal muscles to breathe, you're using your diaphragm. But if push came to shove, you didn't have your diaphragm being functional, you could at least still perhaps breathe by using the intercostal muscles, which means you're going to look like you're winded or you're working kind of hard when you use those muscles to just breathe normally. The cervical nerve plexus, again, C3, C4, C5. Those cervical nerves is where the signal originates before it goes down to the phrenic nerve and then our diaphragm. But if there was any spinal cord injuries above C3, so C1 or C2, that would completely 100% paralyze the diaphragm and any other ventilatory muscles as well. The situation like this happened, where those cervical nerves are damaged, are broken, are cut, if you will. Yes, that it happens. Generally severe trauma, someone falling on their head or neck. I always use in this class as an example, he has since passed, but if anybody remembers, who's as old as me, you remember, but if not, one of the original Superman. 1970s, Christopher Reeve. Played in several Superman movies. He was a very athletic guy, big guy, athletic guy, and he loved to ride horses, and he loved to jump horses. And unfortunately, in really his prime, he jumped one of his horses and he fell off and he landed on his head. Broke his neck, but with that, in turn, impaired his phrenic nerve. From that moment until the day he died, which was like 9, 10 years, maybe even longer later, he did live quite a bit after, he never once was able to breathe on his own because of the damage. So for the rest of his life at that point, he was on a ventilator, 24/7. The ventilator had to breathe for him. So that's what I mean by, any spinal cord cut issues above C3, that means C1 or C2, the patient would not be able to breathe at all, including those intercostal muscles that could function if we had a C3, 4, or 5 issue. All right, before I mention here, let me jump back for just a second. All right, so I just wanted to touch just briefly on the phrenic nerve. That's really why I kind of stuck keeping this here. But if you want to make a note, starting on page 29 in the textbook, all the way through page 35, it's all dealing very nitpicky with the nerves and things like that. I'm omitting from this class right now. We will get that information when we really get into pharmacology, because we can talk about it now and then we're going to talk about it again in pharmacology. So I'm saving you the trouble, because we're going to mention it down the road next semester when we talk about the medications and how they affect the nerves and the nervous system. So from page 29 through page 35, omitting, on page 36, the textbook gets to thoracic anatomy. That's where we're now going to pick up, okay, thoracic anatomy. Is everybody okay what we're skipping? I don't want you to I don't want to spin your wheels reviewing, trying to learn stuff that I'm not even going to test you guys on, or I'm not making you responsible for knowing just yet. So please make sure you note that. All right, the thorax itself. Rib cage is part of the thorax. The intercostal muscles, again, those muscles that are found between the ribs. The vertebrae, again, on the back. The sternum here in the front, as well as the diaphragm. That whole area is known as the thorax. We can divide it right versus left, and even that middle area we refer to as the mediastinum, all part of the thorax. Before I jump to that one, just want to ask, in this picture showing the diaphragm, the right is slightly elevated compared to the left. God bless you. Why is the right slightly elevated? Because of the liver. Why is the left a little bit lower? Partly because the heart may push it down some. Okay, quick read. All right, the ribs. Again, our rib cage structure. We have 12 sets of ribs on both sides, total of 12. The first 7 are considered true ribs. They're called true ribs because they connect directly to the sternum. 1 through 7 connect directly to the sternum. Rib numbers 8, 9, and 10 are referred to as false ribs. They indirectly connect to the sternum through a cartilage. All right, so indirectly connect to the ribs. That's why they're called false ribs. You still have 2 more, ribs 11 and 12. Ribs 11 and 12 do not directly or indirectly connect to the sternum. They are connected on the back, so they are connected on the vertebrae. But notice 11 and 12, they're coming around, but they don't adhere to anything. All right? Those are known as the floating ribs. And again, what do the ribs do? They provide protection for the organs that are behind them, i.e. the lungs, being, in our opinion, one of the most important. We'll get to this in time. If a rib was to be fractured or damaged, what damage could occur underneath that rib, or what things could happen, but we'll get to those things in time. All right, found under each and every rib, there's a costal groove. Now, inside that costal groove, there's going to be blood vessels, nerves found. underneath each and every rib. So you have veins and arteries and nerves found under each and every rib. We mentioned thoracentesis just briefly the other day. We'll get into more details with that down the road. did I mention chest tube?
Yes.
We mentioned pneumothorax, so it makes me think I would have said something about a chest tube. All right. When those things are placed inside the patient, a chest tube or a needle going into the pleural space, when those things are introduced, they're always going to be placed on top of a rib, not underneath a rib. It's the physician that does this, so don't stress as a respiratory therapist. You're not pushing needles or chest tubes into someone's chest. But when they're inserted, they're always inserted above the rib, not below. Why wouldn't they insert it below? Because of those things that are found in that costal group. They don't want to cut blood vessels, they don't want to damage nerves. Now understand, where you're going above one rib, there's a short distance before you get to another rib, so that's why when physicians are doing this, they're being very careful to make sure when they place those instruments, they're feeling they're going just above that rib. Not just kind of picking a spot in between. No, they're going just above that rib.
So no matter what, they're going to be hitting some sort of muscle, right?
Mm-hmm. Oh, absolutely. They have to get through that to get to the lung.
Right.
All right, the sternum. What kind of consists of the sternum here is the manubrium. That's this portion here, the manubrium. You have the body and the xiphoid process here at the end. All that would be kind of classified as the sternum. Right, there's a sternal angle that separates the manubrium from the body. That sternal angle, sometimes called the angle of Louis. I don't know who Louis is, but he got the name here, angle of Louis. Underneath that location, if you can find it anatomically on a patient, just underneath or behind should be approximately, and again, I'm emphasizing that word approximately is where the carina is located, approximately. Again, going back to the xiphoid process. Now, xiphoid process there, it is a loose piece of cartilage kind of hanging there at the end of the sternum. Really no reason for it, but why we need to concern ourselves with it or recognize that it's there and it's a location is we will be doing chest compressions at some point. We will be compressing on someone's sternum. When we compress on a sternum, what are we doing to the heart? We're compressing the heart to try to assist and help the body pump blood because the heart's not doing it itself. So when we're doing resuscitation and we're compressing on someone's heart, we're compressing the sternum. Now, as far as hand placement, where do you put your hand? What is the recommended way to figure out hand placement? Again, my picture's not the best here because I'm missing some things that I'm gonna need to eyeball here. Kind of between the nipple line, right? It used to go, well, 2 finger widths up or 2 finger widths. Find the nipple line, that's where the palm of your hand is going, which is gonna be directly over the sternum. If, however, you have somebody doing chest compressions and they're not sure exactly what they're doing or how to do it, and if they were to get, say, a little too low and they start compressing, they could break off the xiphoid process. Now, if this piece tears, again, notice it kind of comes to a point, it goes in, well, what things are underneath of it? The heart's there, stomach's there, liver's there, again, no telling, again, maybe the angle we're pushing, but there's organs under there, there's important pieces that don't need to be punctured or damaged. And that could all occur simply from somebody doing chest compressions at the improper location. So always make sure when the time comes, I'm not saying it's gonna be next week or the week after, but at some point, you will be there in a resuscitation and you're gonna be watching. And obviously I think the best thing to do is watch one, next one you do, the third one, now you're teaching somebody how to do it, right? But that may be a point, hey, and can someone do chest compressions for 30 minutes by themselves? No, and why would you? We have a staff full of people, students, and sometimes during those resuscitations, people are lining up, waiting for my turn, okay. And you do compressions for a minute, okay, I'm next, okay. And now my turn to do compressions. And when you do one the first time, you're gonna realize You're going to realize 15 seconds in, holy cow, this is work. This is hard. But thank goodness there's a line of people. And when, okay, ready to trade off? Okay, switch. Now I'm going to go back to the line and I'm waiting my turn again. Here I go. So make sure hand placement when we do chest compressions that you know where you're going to put your hands. The ribs do move, obviously, during breathing. The ribs do need to increase the thoracic diameter of our chest to give our lungs an opportunity to expand. So during breathing, the rib heads rotate on the vertebral articulations. That's on the vertebrae on the back. The vertebrae itself remains stable. It's the ribs that move on those vertebral articulations on our vertebrae there in the back. The sternal ends, the ends that come around that are attached to the sternum, also will move. And how they move is slightly different. So on the vertebrae, the ribs kind of rotate, where at the sternum, they rise up. And so let me give you kind of a picture here, and then I'll show you the example the textbook likes to use. So the rib, here's the portion that's attached here to the front, all right, to the sternum ultimately. Here's to the front. This is the spot that's there on the spine or the vertebrae. So where they attach here, these things will rotate, okay? They'll rotate, whereas the attachments that's here on the sternum will rise up, okay? Your textbook uses this very basic example as a way to remember that, all right? And it's this bucket and pump handle rib movement. Okay, on the vertebrae, they are rotating. Or excuse me, the vertebrae, they're rotating, excuse me. The vertebrae, they're rotating. Whereas on the sternum, they're rising up. So if you think about a bucket and a bucket's handle, how does a bucket handle, how would it raise? It would do something like this. So if, again, think of your vertebrae, your spine, the ribs are moving in this direction. On the vertebrae, on the back. Whereas in the front, the sternum, what are they doing? They're rising and falling, going up and down. So this is one of those things like patting your stomach and rubbing your head. Please forgive me. I'm not on video, am I? All right. Yeah, well, I know. All right, so they're doing these motions all together, all right? Notice I'm rising up and down and that pail handle movement here. So all this is happening when our ribs are moving. And what's happening underneath where the lungs are expanding and contracting if we're now exhaling. Okay? That's the only kind of example to kind of describe that motion of our ribs when they move. So all of this increases thoracic cavity volume, again, to allow the lungs to expand. And it creates pressure gradients. We'll get to those in another chapter. Pressure gradients that are necessary for air to flow. All right, the muscles, ventilatory muscles. Again, I'm going by the textbook here, so trying to stick with how the textbook lays it out. Primary muscles used for quiet breathing, or what I would refer to as just normal breathing, the breathing you're doing right now. Again, those primary muscles are the diaphragm. And if I was the author of this textbook, I would leave it there. The diaphragm, primary muscle. The peristernal intercostal scalenes can be used, but to a much, much, much lesser extent during normal quiet breathing. But the primary muscle of ventilation is the diaphragm, hands down. Hands down is the diaphragm. Now these other muscles, scalenes, sternomastoids, pectoralis, abdominals, all these are considered what we call accessory muscles. Accessory muscles. Now, right now, everyone in here looks comfortable. Nobody took the stairs 2 seconds ago. Everybody looks comfortable in your breathing, right? You are not using any accessory muscles to breathe. If I was to say, okay, let's race up and down the stairwell, and then we start looking at each other, yeah, you're going to see some of these other muscles that we're not seeing being used right now. Those are considered accessory muscles. Accessory muscles are used when there is an increase in the patient's work of breathing. Now you can picture yourself, if you sat there and did something aerobic, you sprinted back and forth or ran up and down the stairwell, you're needing some more muscles than just the diaphragm to breathe, right? You're using all those extra muscles. You can see it. Your work of breathing is increased, but you were doing some sort of aerobic activity, you needed that assistance. So you can breathe a little bit easier and better, getting more oxygen into your bloodstream for the muscles that are now working. Well, what about my patient in the hospital bed who's not doing anything aerobic, not doing anything physical? They're just lying in bed, but they're in so much distress because of their illness or their disease that you're noticing all these extra muscles being used. And so those extra muscles being used, not the diaphragm, but those extra muscles being used, we refer to those all as accessory muscles of breathing. You can see the first three here under accessories are used for inspiration, with the abdominals strictly only being used during exhalation or expiration. All right, the diaphragm, again, primary muscle of ventilation. It will move, allowing us to breathe. The diaphragm does separate into the right and left hemidiaphragms, so they are somewhat independent from each other. That's why if I have one phrenic nerve that's knocked out, the other one can still function. That diaphragm anyway can still function, but it can't cause the other diaphragm to move. The diaphragm, so remember this about the diaphragm. Does the diaphragm move up or down when you inspire? Does it move up or down when you inspire? So when you breathe in deep, does your diaphragm want to go this way or does it want to go this way? Well, if you inspire, it better go down. Again, think about your lungs filling. Your lungs getting bigger, your diaphragm's going down. And it's not the lungs filling that causes the diaphragm to move, it's the diaphragm moving that causes the lung to fill. Okay, so it's the diaphragm going down, now the lungs are expanding. When you exhale and the diaphragm goes up, now you're exhaling. Okay, so important to know kind of the direction the diaphragm moves. We will talk about later ways you can help coach your patient on how to breathe. Breathing with their diaphragm. Sometimes you just simply tell them, put your hands on your belly, diaphragm, and focus on your belly, talking to my patient, your belly expanding. That's your diaphragm moving down. To really focus on breathing in deep. So when the diaphragm moves down, descends, it creates a three-dimensional increase in thoracic volume. Again, allows the lung to expand. Allows the thorax to expand. So the ribs, again, are doing their motion. The bucket handle and the pump handle motion. When that occurs, again, picturing you guys, you're breathing normal right now. Your diaphragm's only moving around 1.5 centimeters. So that's not much. It doesn't have to move much. And that leads to your normal tidal volume, the breath you're breathing in right now, with that very small movement of the diaphragm. That's all you need. Again, it doesn't have to move much. However, if you needed more air, you needed a bigger breath. Again, you're running up and down the stairwell. You need a little bit more wind. You need that. You can make your diaphragm move even more. It can move 10 centimeters. If 1.5 gives you 500 mLs, what do you think moving 6 to 10 centimeters could add as far as volume goes? So now you're talking, it could be liters worth of air. Again, my water bottle, always come with a water bottle. My water bottle is 500 mLs. 1.5 centimeters moves 500 mLs of air. If I quadruple plus whatever 5 times, 6 times, whatever that is, how much more volume can I move? Probably anywhere 2, 3, 4 liters perhaps to get more air than just your 500 mLs. So under extreme ventilatory demand, we're really moving that diaphragm to try to pull in more air, more volume. Now we all can experience this just by doing anything aerobic, where you need a little bit, your respiratory rate increases, your heart rate increases, you're running on the treadmill, you're biking, you're running, jogging, whatever the case may be. We all experience that and feel it. Going back to my sick patient. My sick patient who needs more air. Again, I'm going to use grandma as the example again. Do you think grandma can move her diaphragm this much? Probably not. That's because she's weak, right? Her respiratory muscles are weak. She would love more air, but her diaphragm can't move this much because she is so weak. So what happens to her volume of air inside of her chest? It doesn't really increase, or can't increase that much. Right? The diaphragm during exhalation. Now, typically during exhalation, our diaphragm does not have to be active for us to exhale. I need it to inhale, but I don't really need the diaphragm when I'm exhaling, because we consider exhalation to be passive. The recoil of the lung, the normal recoil of the lung, leads to exhalation. So when I say passive as opposed to active, I could make myself actively exhale right now. I'm actively exhaling, but I don't need to breathe that way normally, right? I can breathe in using my diaphragm. Once my lungs are full, I can then just passively exhale. I don't have to think about it, but it's the recoil of the lung. And we'll get into the recoil of the lung and things that could affect recoil of the lung a little bit more in due time. So make sure, I meant to highlight that too, or bold it. The elastic recoil of the lungs is how we normally exhale. So you may want to highlight that or underline it or do whatever you need to do to remember that statement. The elastic recoil of the lungs is typically how we normally exhale. Again, with normal breathing, normal, quiet, resting breathing. Sometimes the diaphragm, I don't like to use this term, but I'm going to say it anyways, can get stuck. Okay? Technically doesn't get stuck, but the diaphragm that normally has a nice rounded shape to it, again, right side being a little bit higher than the left side, but nice dome shape. Sometimes that dome shape can be flattened out, where you don't see that nice curvature of the diaphragm. It really flattens out. We see this in patients who can't normally empty their lungs, can't exhale normally. Again, this is seen with our patients with respiratory and lung disease, especially patients with COPD and or emphysema patients. What ends up happening, because they can't normally exhale, and again, without getting too much into it, now, their disease process affects the recoil of their lung, and so they lose that recoil of the lung, and so their lungs inflate, but they don't have the recoil like you and I to get that breath out. What ultimately ends up happening to these poor folks is they retain their air. They retain the volume of air they just inspired. They keep a little bit of it kind of stuck in the lung. We call that issue, phenomenon, if you will, air trapping. They trap air. And because of their disease and illness, they can't get rid of it. And so what happens? They take another breath in. Some air gets stuck. They get some air out, but some of the air gets trapped or gets stuck. And as that happens over time, what happens to the diaphragm? Instead of being nice and curved, it ends up getting flattened out from all of that trapped air. We'll get to these details as we kind of go through this semester and even into next semester for these patients with COPD and or emphysema. But it lowers thoracic dimension, lowers their inspired volumes, so they can't breathe in as much because there's already air that's what? Stuck or trapped. That air trapping that occurs. Another thing here, if the diaphragm was to be paralyzed. Paralysis of the diaphragm, the paralyzed diaphragm could be sucked back up during inspiration. So it kind of creates this seesaw appearing breathing pattern. Sometimes we call it paradoxical movement, where everything kind of moves opposite from the way it's normally supposed to. Again, seen with a paralyzed diaphragm. Going back to the flattened diaphragms though, if on my right, your left, if that's how the diaphragm, that kind of rounded shape, dome shape that's supposed to look, if there's trapped air from COPD or emphysema, it flattens, it pushes the diaphragm, keeps the diaphragm flat. These patients have old, stale air in their lungs that they can never get out. And we'll get to this in the assessment class later. You may hear the term a barrel-shaped chest. Barrel-shaped chest. It's the COPD and or emphysema patient that has that shaped chest.
So if you're looking at like an X-ray and it doesn't come to like the point
It's not, that's a good, it's not necessarily the costophrenic angle. It's not necessarily costophrenic angle. Thank you, we're like right here. So, instead of it being kind of curved, it flattens out. So you can see it on x-ray. This one's not the easiest or cleanest one to see, okay? But just comparing the normal one where you do see the curvature of the diaphragm to this one where you're kind of missing or losing out on that curvature, the costophrenic angles or recesses that you're referring to still can be present, but you end up seeing the diaphragm more flattening out instead of having that kind of dome-shaped appearance.
Is that like the indication of trapped diaphragm?
That's one of them. Yeah, it's one of them. Again, this is not the most perfect x-ray of this, but this patient on your right here is a COPD patient. I can notice their ribs. There's, instead of the ribs being kind of rounded, the ribs kind of flatten out somewhat, again, from all that trapped air that is in their lungs, in their chest. That's why they don't oxygenate very well, because they have old, stale air that gets trapped inside their chest. All right, the intercostal muscles, like we mentioned before, those are the muscles found between the ribs. Okay, the muscles found between the ribs. Now, I'm not going to get all nitpicky on you guys, having you guys be able to fill out a diagram of these are the internal, these are the external. Do you use the intercostals when you're doing normal breathing? Typically not, it's the diaphragm. But if you needed a little extra assistance, you could use those intercostal muscles. So I say intercostal muscles are mainly used during active breathing where you're really trying to move some more air, maybe because you're exercising, or for a patient because they're sick and they're having trouble breathing, but generally not being used, the intercostals generally not being used during just passive breathing.
So on the last slide with the x-ray, their ribs are, they're thinner? Do they?
The spacing between them kind of, sorry to keep using this term, flattens out.
Mm-hmm.
Instead of being kind of curved, they tend to flatten. So if the ribs kind of slant, using myself as a slant downward, for these patients with the air trapping, they kind of straighten out, if you will.
So would they be easier to break then, or?
Not necessarily, no. Doesn't change the structure of the bone itself, but the shape of the chest ends up changing. And we'll get to that in time. I'll talk more about a barrel-shaped chest later. But the shape of their chest does change. I'll show you actually a picture of a guy with a barrel-shaped chest in just a second. Move to the next one. Scaling muscles. Again, accessory muscles of breathing. You normally don't use your scalene muscles. Scaling muscles all here in the neck. Scaling muscles are attached to the first two ribs. And if you're in distress or you're exercising really, really hard, you need a little bit more air, a little more oomph, or your patient who is extremely sick, having trouble breathing, they need to try to pull in some more air, they can use the scalene muscles. Again, they're attached to the first two ribs. They try to pull the thorax out to try to allow the lungs to expand even more. That's why normally, you guys breathing right now, I'm not seeing any scalene muscles being used. There's no muscles in your neck right now that's being used to breathe. So again, you walk into a patient's room, you see those muscles in their neck really pulling. They're really trying to breathe. Right there, you're seeing a patient who has increased work of breathing. Someone who I would say appears in distress. Sternomastoid muscle here, again, they're on both sides, but this one is here, down to the sternum, originating actually up into the skull, but going down to the sternum. Again, another accessory muscle to try to expand the thorax, to try to increase the diameter of the thorax, to try to allow the lungs to expand even more. Again, generally not used during normal breathing, only if we need help. Again, why it's another accessory muscle to breathe. Again, can help to elevate the sternum and the anterior ends of the rib, trying just to expand the thorax as much as possible. I think I have one more. Okay, the pectoralis, so the big fan-like muscle there on her chest, big, huge, strong muscle of the body, that can also be used for breathing, but it is classified as an accessory muscle to breathe. Diaphragm is your primary. Your pecs can be used as an accessory muscle to breathe. Again, going from the sternum here in the chest all the way to the humerus of the arm. If and again, normally not used during normal, quiet, regular breathing, but if our patient, again, using an accessory muscle or using accessory muscles, plural, to breathe, they can use their pectoralis major muscle to try to increase the diameter of the thorax. And so my example here, typical posture of a COPD patient, that tripoding position. They may, and you may coach them for this, or they may just figure it out on their own. I could breathe a little bit easier if I kind of spread out and focus on breathing this way in kind of a tripod-shaped position. I'll show you a better picture, I suppose, of me doing it. But it helps to elevate the sternum and the ribs. This gentleman, okay, here is our typical emphysema COPD patient. Weight-wise, he's probably very light. He's probably very thin. You see his ribs, the bones, but he has a barrel-shaped chest because of the air that is trapped. Notice his positioning, that tripod position. I know he's in a chair. Patients could be sitting off the edge of the bed, leaning on a bedside table, trying to create a similar tripoding position. To again, use the pecs to try to increase the thoracic diameter, to again, hopefully try to help them get more air inside their chest. Notice also, and I'll use this example in another class on another day, do you see his lips? They're a little blue. I'd say, yeah, I agree, they are a little blue. But the way he's breathing, he's breathing through what we call pursed lips. Patients will sometimes figure that out on their own, that it helps relieve their work of breathing if they exhale through pursed lips, like they're blowing out birthday candles or something like that. You know why? You know what makes them do, or what that does for the patient? Because these patients with COPD and emphysema, they lose the elastic recoil of the lung and they trap air. Their distal airways tend to collapse when they're trying to exhale. Those distal airways collapse, trapping air behind it. So again, it's that air they can never get out. But if they exhale through pursed lips, that pursed lip exhalation keeps the airway stented open instead of collapsing, keeps the airway stented open so all that stale air that's behind it could get out. So it prolongs exhalation, so their exhalation is going to be a little bit longer than it normally would be, but that's okay. They're getting some of that old stale air out of their chest. So it might really help to relieve their work of breathing. And many times you're going to come across a patient who you may say, you know, I'm seeing some accessory muscles in action here. He's in a tripod position, he's pursed lip breathing. He's doing all of that to try to improve what he's feeling, that increase in work of breathing. And many times patients don't have to be taught this, they figure it out on their own. I saw some hands go. How
long does it take for a normal COPD patient to kind of filter all of that air out of their...
Well, I wouldn't say they're going to be able to filter it all out, but they're going to be able to get some of it out. Okay? So depending on the degree of COPD, how severe their COPD or emphysema is, every patient can be a little bit different. The more severe patient's going to have even more trouble getting some of that air out. But as far as getting it all out with that disease or illness, I'm going to say no, they're not going to be able to get it all out. But by doing some of these techniques and some of these things, it will help to get some of it out. Again, if they can get some of that stale air out, that means for their next breath, they can get some fresh air in, fresh oxygen in, to be able to participate in gas exchange. Any other questions? Yes?
Can you explain the barrel thing again?
Okay, so, and we'll get to this, I want to say in the assessment class later, but I will share it because it's important. We're going to see it quite a bit. It doesn't mean that the patient is fat or the patient is large, because this guy is not fat whatsoever, but he has a barrel-shaped chest. Remember what's happening. They're trapping air that can't get out.
Basically looks like they're blown up, right?
So that will actually change the circumference and the diameter of the chest. And it would happen to me and you over time. The more air we trap, the more our thorax is going to kind of change shape because of the air that we can never get out. And so You see that more in your chronic lung patients, like COPD, like emphysema, cystic fibrosis. Cystic fibrosis patients tend to be fairly, very, very thin. They could even have a barrel chest. I have a friend who has cystic fibrosis, and he is as thin as he can be. He eats 3 times more than I do, but he can't gain weight. But that's part of the illness. That's part of the condition. And he has, even though he's thin, has a barrel-shaped chest from the air that he traps because of his chronic lung disease. I know that was very kind of abbreviated or quick, but it's from all that trapped air. All that trapped air ends up changing the kind of the physical structure of the chest.
I think it's easier to see too on the side, right?
Yeah, yeah. I know it's hard to see the picture here. His pants are unbuttoned. He's trying to allow his diaphragm to have as much free movement as possible. So there is no restriction in his own breathing. Of course, he's wearing oxygen. He has a pulse oximeter on his finger. Wish I knew what his numbers look like, but I can only assume they must be typical for an emphysema/COPD patient. All right, last one. Last one, thank you. Last one here, the abdominal muscles. Abdominal muscles not used during inhalation and generally not used during exhalation. What causes us to exhale? The passive recoil of the lung. The elastic recoil of the lung allows exhalation. However, if you wanted to forcibly exhale, you could by using your abdominal muscles. Okay, so if you really wanted to forcibly exhale. Now, for us, generally, we're not forcibly exhaling. You could say, well, when you blow out birthday candles, aren't you forcibly exhaling? Kind of, but I don't really need to use my abdominals. But when we do lung function testing for our patients and we coach them, hey, breathe in deep. And here's the second part. After you breathe in deep, hold it. Now I want you to blast that air out as fast and as hard as you can, because we're doing measurements when pulmonary function testing. You coach them up for that. They're going to be using some abdominal muscles to forcibly exhale.
Like a breathalyzer test too?
Similar.
Not that I'm taking
Different
it.
purpose. Yeah, now that you know anything about it, right? Yeah. So that's what I said. Normally inactive during normal, quiet, resting exhalation. My last little concept question here, why might a person with and we actually talked about this before, major abdominal surgery be at risk for retention of airway secretions and possible pulmonary complications like a pneumonia?
They don't want to move because it hurts.
Because they don't want to move because of the pain, because it hurts. So as a respiratory therapist, yes, already get it set inside your mind that you're going to be visiting some patients and treating some patients that just don't want to do things because, and I get it, it hurts, and I don't mean to minimize their pain whatsoever. But show them, tell them why the importance here. Maybe even, if you're being nice, maybe even try to time your visit maybe 20 to 30 minutes after they receive their most recent dose of pain meds, so they're not hurting. You know, if you can time it just right, as opposed to say 20 or 30 minutes before their pain meds due when it's really worn off, yeah, it's gonna really hurt them. We mentioned the pillow thing the other day, so this helps splint. That's another little trick we can teach them. Those abdominal surgical patients who may be struggling to cough, to deep breathe, to cough, exhale, etc. All right, that was my last slide. All right, any questions before I give you my questions? Okay. All right, this was not from today, so let's see what you remember. How many lobes are there on the right versus the left? How many lobes are on the right compared to the left?
3.
I hear 2. I hear 3. 2 and 3. Okay, that's right, but which is which? How many are on the right? 3. 3 on the right, that means there's 2 on the left. Again, always think about where the heart is. Remove one of the lobes because of the heart being in that spot. All right, so what was the right answer anyways? C. Thank you. C. 3 on the right, 2 on the left. But you can see how the test is going to appear. You may remember, and I'm not saying that you'll remember it like you're supposed to remember it right. There's going to be some people that are going to like, oh, I know there's a 3 and a 2. And then give you something like that. And with 23 people, I guarantee, and it might not even be intentional, somebody's going to see it and go, oh yeah, 3 and 2, and pick that. and miss a very easy question, right? When clearly it's 3 on the right, 2 on the left. All right, next question. What's the name of the blood vessel that carries deoxygenated blood to the lungs or alveoli specifically? Is that the pulmonary artery, pulmonary vein, aorta, or carotid artery? Pulmonary artery carries the deoxygenated blood. Okay? Carries the deoxygenated blood. Now just again, try to help you as much as I can before we test, right? Because at some point I'm going to stop dropping hints when there's a test upcoming. Knowing how I use these to rewrite a test question. If I take this, and I'm not saying I am going to do this one specifically, but it makes me think, and I honestly don't even know if I've written one like this. But when I see this, this is what starts going through my mind. Well, I don't want to give you the same exact question verbatim. But I replace the question with the word oxygenated. But I give you those same 4 options. And I know there's going to be people that take that test that day, they're going to vaguely recognize this question, and the answer was A, like it is today. But when I take this and say it's oxygenated blood, well, where does the oxygenated blood go? Pulmonary veins. So be careful on questions like this. So if you look back at any questions I give you at the end of a lecture or at the end of a chapter, and you review them, and you're like, yeah, I got that one, okay, I'm looking at all these other, I got all those. Just remember what I could do to those questions. Change it ever so slightly, and now there's a new correct answer. So don't let me trick you on that, because I'm going to do it. Yes, Julian?
I don't know if it helps, but for me, it helps to remember what we learned, like in the past, that the arteries carries blood away from the heart. So if they oxygenated, and then they return through the vein, but away from the heart. So it's with the lungs,
Right.
they are away, so we can
And that is
artery.
That is
So that can
absolutely true. That is absolutely true. Because many times, you think about the body, most of the oxygenated blood is in an artery. Whereas the deoxygenated blood's in a vein, like the veins of the back of my hand. You know, it's not true here. It's the exact opposite. But it does relate to vessels that are going to the heart as opposed to coming away from the heart. So that is exactly true. All right, I got a couple more questions here. What is the major or primary muscle of ventilation? Intercostals, pectoralis, scalene, or diaphragm?
Diaphragm.
When I ask that question, you better not get this one wrong.
Diaphragm.
Better not get this one wrong, right? Said it umpteen times, and you're going to hear me say it 1,000 times more. Diaphragm, primary, major muscle of ventilation. Used during inspiration or expiration? Inspiration. Inspiration. Next question, what nerve innervates the diaphragm? Vagus, phrenic, radial, or ulnar? Phrenic. Now, with this question, again, we only talked about one nerve so far, so hopefully that would be very easy to recognize and remember. But I will say in the future, we actually talk about every one of these nerves for other things. And so, a semester or 2 from now, I ask the same question. Hopefully you get it right, but there could be some pause on your part because, yeah, we've talked about these other nerves and how do they kind of work in this thing?
I would coordinate phrenic and diaphragm, both have PHR in them.
Okay, okay, I got you. I'm all about any shortcuts or things. Now, some folks may have, and I've had students tell me before, John, I don't want to say this my way to remember it in front of the class because it's a little embarrassing or maybe it's a little weird or whatever. Hey, the weirder it is, the more you'll remember it, just being honest. I didn't say perverted, but that sometimes helps too. Was there another question? Let's see another. All right, I think that was my last question. Yep, that was my last one. So any questions for me, guys? All right, are we meeting this Friday? No. No yeses in here. You can come out here, but you're not going to be in the lab. You'll